Today I'll be taking about GIT few topics. So
Yes.
the introduction topic is dysphagia. So what is
Oh,
dysphagia? Dysphagia is a term which you have heard normally in actually in GI medicine. The patient comes with like difficulty in swallowing, or you might find that the patient has a difficulty in eating food. So that's
okay.
difficulty in swallowing, and it may coexist with heartburn. Heartburn is actually the retrosternal pain that is behind the mediastinum. You feel like a burning sensation in the
Okay.
esophagus, and
Okay.
or it might be associated with vomiting or nausea.
Okay, sir.
So different type of dysphagia I'll come into later. I'm just making you familiar with few of the terms which are
Yes, sir. Yes.
regularly used in our clinical time when you
Yes, sir.
do the case
Dyspepsia
taking and
also.
all. Like when you use medical terms, as one is dysphagia, they might
Yes.
say dyspepsia. So
Yes.
what is dyspepsia is symptoms such as there will be discomfort, bloating, and nausea. So
Yes.
in dysphagia is difficulty in swallowing, whereas dyspepsia, so it's actually there in the word only. Dys means actually difficulty.
Yes.
Pepsia means like there is increased peptic acid secretion. So once there is increased peptic acid secretion, there'll be what? There'll be bloating of stomach. There'll be heartburn. There'll
Yes.
be like discomfort in the stomach. The patient might feel discomfort, like the stomach is like fully filled with gas. And can't sit properly. You may
Yes.
pain or something like that. So there is some discomfort, and there'll be
Okay.
bloating, and there'll be also associated nausea.
Okay, sir.
But there won't be any difficulty in swallowing in dyspepsia.
Okay, sir.
Okay. And it originates from, and most of the time, dyspepsia, it originates from the upper GI tract, that is the stomach, esophagus, then the duodenum. That's the upper GI tract. Duodenum, jejunum is the up to jejunum is the upper GI tract mainly.
Okay.
Duodenum, middle of second part of the duodenum is the upper GI tract, and below
Okay.
that is the lower GI tract.
Okay, sir.
Okay. So next is what are the causes? There, what examples of the upper, what cause of dyspepsia is upper gastrointestinal disorders like peptic ulcer disease, acute gastritis. Then next is gallstones in the gallbladder. So they are
Okay.
gallstones. So once there are gallstones in the gallbladder, there will be decreased secretion of the bile into the second part of the duodenum. So the bile is actually helps in digestion, and there will be indigestion. It causes dyspepsia. The next is
Okay.
esophageal spasm. Then there will be other causes like non-ulcer dyspepsia and irritable bowel syndrome. Then
Okay.
other gastrointestinal disorders like pancreas, any pancreatitis or a cancer can cause also dyspepsia. Then next week colonic carcinoma. Then hepatic disease like hepatitis or metastasis also can cause dyspepsia. Then systemic diseases like which is not GIT causes like renal failure. Then hypercalcemia by increasing serum calcium levels. Then there are drugs like NSAIDs, like the aspirin. Aspirin were widely used, and at that time, aspirin is a very classical what example for causing gastrointestinal disorders, or it causes dyspepsia. Then glucocorticoids, steroids, then iron and potassium supplements. Iron supplements in a clinical practice, you might see patient in, especially in OBG, where the patient will be prescribed with iron, and the patient will come next day that's telling that I have got loose stools or I have got gastritis. So iron supplements you see a lot of time dyspepsia. Then with digoxin. Now other psychological disorders also is associated with dyspepsia.
Okay.
Anyway, I actually just gave a vague idea. It is
Yes, sir.
not a detailed explanation. Acute
Yes.
gastritis, esophageal spasm, peptic ulceritis. Again, I'll be explaining each and
Yes.
everything in the
Yes.
different topics.
Yes.
Then there are alarming features of dyspepsia, because dyspepsia causes is a discomfort, and there is the blotting of stomach. So once there is blotting of stomach, the patient will find discomfort, and they will present with lot of other symptoms, like there'll be, along with dyspepsia, there'll be weight loss, there'll be anemia, there'll be vomiting, there'll be hematemesis or melena also. Melena is black tarry stool, and hematemesis is presence of fresh blood in the vomit. It's called
Okay.
hematemesis. And there
Okay.
will be dysphagia also associated with dyspepsia,
Okay.
because the patient, because when he have food, he'll have the like gastritis, and there'll be blotting of stomach, so he'll not start having the food. He won't feel hunger or anything, so there'll be dysphagia also. And there'll
Okay.
be palpable abdominal mass also, like in hepatitis or hepatomegaly also will cause dyspepsia. These are the alarming features, just keep in mind. So
Okay.
next is heartburn and regurgitation. I told you heartburn is actually, it describes retrosternal burning discomfort, often rising up into the chest. So there is a discomfort in behind the mediastinum, that's the retrosternal region, as in the esophagus, and the person will like feel that the irritation or the burning sensation is rising up into the throat, that's up into the chest.
Okay.
So that is called heartburn. Then
Okay.
sometimes accompanied by, it might be accompanied by regurgitation of the acid. That's the gastric acid. There's a peptic acid and the HCl. There might be regurgitation, and this regurgitation also will cause it can reach up to the throat. So it will cause bitter fluid in the throat. Sometimes when we have heavy food, we feel like that, we feel nausea and regurgitated. That's a bitter food which comes into the throat because of the bitterness is due to the acid present in the stomach.
Okay.
Okay. So what are symptoms are often occurs following a meal. So once a person has meal, if after the meal he will start feeling regurgitation and he'll feel heartburn. And on it suddenly, so there's a trend like after having lunch they feel you have to take a short nap in the afternoon. So once soon after the food, right, if he lies down, he will again get heartburn. So that's why we tell to the patients, as soon as you have a lunch or a meal in the morning, afternoon, or night, we should not sleep as soon as we have the lunch food. So you should actually sit for some time, and after half an hour or 45 minutes, then only we have to lie down. Otherwise, when you lie down, you'll feel heartburn or you'll feel regurgitation of the contents of the stomach into the mouth. Then again, if the person after having food, he goes have to do any heavy exercise or he bends down, again it will cause the heartburn because the food from the content from the stomach is pushed into the mouth that time, or when he's doing lifting work, he again exerts pressure in the abdomen and it will cause regurgitation of food into the mouth. Patient also will present along with heartburn. They'll present with chest pain. There'll be belching. There'll be halitosis. Halitosis is bad smell from the mouth.
Okay.
So that halitosis because he'll be always regurgitating the food into the mouth, and that will cause halitosis.
So what is belching, sir?
Pardon?
Belching.
Belching is an embecum. Like you after having food, you produce a small sound, right? That's called belching.
Okay.
That is the releasing of the gas from the stomach.
Yes, sir.
Yeah. So actually, it's not supposed to come, but when there is a lower esophageal sphincter weakness, the gas from the stomach pushes into the mouth.
Okay.
That's belching. Belching or retching, it is called. Okay. Then this because of regurgitation, right? He will also have chronic cough because on regurgitating. What is regurgitation? It's like a same like a vomiting only. So it is like forceful expulsion of the content from the stomach into the mouth. So once there is forceful expulsion in the reverse peristalsis, this content of the mouth also can go into the airway, the trachea. So once it goes into the trachea, we will have chronic cough, and he might present with pneumonia also. And it will also cause, and this acid, when it's exposed into the mouth can't hold this acid. On exposure to the acid, they will cause burns and they'll cause irritation, redness, erythema, and it will cause also sore throat. So that time you might get patients like when you're having gastritis, you might always say, my throat is burning.
Yes.
Yeah, that is sore throat actually. So you understood heartburn and regurgitation, right?
Yes.
Oh, fine. So there's anatomy. There's next thing coming to tell about gastrointestinal bleeding. It's a very common topic. Gastrointestinal bleeding is a actually 10-mark topic, or they might ask you like, how is a question paper made? Actually 10 marks, 8
10
marks,
marks, 5 marks, and 3 marks.
Okay, like old way, same thing.
Yes,
10 marks,
yes,
5
sir.
marks, and 3 marks. So this gastrointestinal bleeding can come 10-mark topic, or it might come as 5-mark topic also.
Okay, sir.
So there's gastrointestinal bleeding is this one. So there's an anatomical demarcation is the ligament of Treves. It divides the GIT into the two parts, upper GI and the lower GI. And it's the ligament of Treves which is located at the duodenum. That's what I told you. Between the duodenum and the jejunum, there's a flexure. There's a duodenal flexure, and that flexure is called ligament of Treves. And this ligament of Treves divides the GIT into upper GIT and the lower GIT. This is a clinical question. They might ask you during the viva, what's the demarcation which divides the GIT into upper GIT and the lower GIT. That's why you have to remember ligament of Treves, which is present at the duodenal jejunal flexure. Okay. And and there are two types of GI bleeding. It's upper GI bleeding and the lower GI bleeding. So what is upper GI bleeding? Is the vomiting of bright red vomiters, that is hematemesis. That's what I told you. When the vomit is mixed with bright red color, it is blood, that is hematemesis. It might be also followed, upper GI bleeding might be also followed by actually a coffee brown color blood vomiters also. This coffee brown color vomiters is because the blood, it mixed with the acids, and this acid, right, it converts the hemoglobin into iron. Okay. And iron is what? It's brown in color. That's a normal iron rod. It's brown in color, right? So this iron is breaks down the RBC and it releases the iron, and this iron is found in the vomit. So that's why the vomit might be coffee brown color also.
Okay.
Okay. So followed by coffee brown color due to the formation of acid hematine. Hematine means heme, that is the iron.
Okay.
Okay. So next is what are the causes? What are the different causes of upper GI bleeding? That is esophagitis. Then what it might be, actually esophagitis is the phagitis. What is esophagitis? Is the inflammation. Itis means inflammation. Always
Okay.
remember esophagitis. Then next is pharyngitis. Itis is always inflammation of that particular pharyngitis.
Sure.
Esophagitis is inflammation of the esophagus. This inflammation may be usually with it may be associated with hiatus hernia. Hiatus hernia means hernia which of the diaphragm. Hiatus means diaphragm. Hernia of the diaphragm is called hiatus hernia. So this esophagitis might be associated with hiatus hernia. And next is
Okay.
okay, upper GI bleeding also is found in when there is liver diseases, and when there's portal vein thrombosis also you find upper GI bleeding. And it's
Okay.
also seen, I told you, NSAIDs, that is the aspirin and other non-steroidal anti-inflammatory drugs also can cause peptic ulcer bleeding. And
Okay.
other one important cause is Helicobacter pylori. As a Helicobacter pylori is a bacteria which causes the peptic ulcer disease, and it will cause upper GI bleeding. Upper GI
Okay.
bleeding is also seen in vascular malformations. Then when there is cancer of the stomach or the esophagus also is seen, and when it's alcohol intake, how it causes upper GI bleeding, that is the Mallory Weirs tear. I'll come to and tell you what is Mallory Weirs tear in the next slide.
Okay.
So now you so like I'll tell you each and everything. See, what is the most common cause of upper GI bleeding is the peptic ulcer disease. Remember that. Most common
Okay.
cause. They might ask you what's the most common cause. That is upper GI bleeding. Most common cause is peptic ulcer disease because of Helicobacter pylori. Then the
Okay.
drug which induces the bleeding is the COX-1 inhibitors. That is example is aspirin, ketorolac, and pyroxicam. This ketorolac, pyroxicam, and aspirin were before used a lot for as a painkiller. So that's
Okay.
why it had everybody was prescribed with these drugs and these causes. Later on, they found out that this had a side effect causing upper GI bleeding. Then next,
Okay.
esophageal varices. Esophageal varices is actually like hemorrhoids. Is there? You know what is hemorrhoids?
No, I sir.
Yeah. You don't know what's hemorrhoids?
No, no, I know, sir.
Yeah. So same like hemorrhoids, that's in the rectum. So this one, no, there is dilatation of the vessels in the esophagus.
Okay.
That's esophageal varices. It may be due to portal hypertension, which leads to upper GI bleeding. Then next I
Okay.
told you Mallory-West here and Delphois lesions and Borheim syndrome. All these three lesions I will come into the next slides. I will be explaining. So you
Okay.
understood till now, right?
Yes, yes.
Okay, no doubts, right?
No doubt.
Okay, fine. So now I tell you what is Mallory Westier. Mallory Westier is a very important topic. They might ask you for 3 marks in individually for 3 marks. So
Okay.
Mallory Westier is a submucosal. Remember, it is a submucosal tear. It does not cause complete tear of the esophagus. It only causes a submucosal tear. Then its location is at the cardia. That is cardia of the stomach. Where is cardia located? It's located on the lesser curvature of the stomach. Remember that.
Okay.
Okay. Then it's associated with binge alcoholism. What do you mean by binge alcoholism? Means people you suddenly drinks a large quantity of alcohol,
Okay.
and that will cause vomiting,
Okay. Okay.
and this vomiting will cause the tear.
Okay.
Then
Okay.
next is also associated with hiatus hernia, as I told you, hernia of the diaphragm, and it also associated with hyper. I told you vomiting. So it's what is the other type of vomiting which is forceful vomiting is hyperemesis gravidarum. That is vomiting in pregnant women, early morning vomiting. So that early morning vomiting comes in a forceful manner. So
Okay.
it is hyperemesis gravidarum. It is okay. Now I'll come to diagnose. How do you diagnose? That's the investigation. Investigation is by the upper GI endoscopy. Remember
Okay.
that. On upper GI endoscopy, what do you find? Active bleeding, and or you might find a adherent clot or a fibrin crest over a mucosal split within or near the gas. Where do you find? At the gastroesophageal G junction. So
Okay.
Mallory Westia, I told you what it is found at the cardia or the lesser curvature. Also, you will find these clots in the upper GI because
Okay.
at the gastroesophageal junction and cardia is nearby itself. So you'll find these clots or active bleeding in this upper GE gastroesophageal junction.
Okay.
And these slits will be about 2 to 3 centimeter in length. It's associated with binge alcoholism, hypersomnia, hypersensitivity, grammida. Already I told you.
Okay.
The next is, so that is what Mallory Westier is. So next is Voorhees syndrome. Voorhees syndrome also it's associated with forceful vomiting itself, but it might be actually might be actually due to various other causes of other than these Mallory Westier causes. And in Voorhees, no, it leads to esophageal rupture at the lower 1/3 of the esophagus, and it is posteriorly located.
Okay.
Other one, Mallory Westier was where it was located in the cardiac at the lower gastroesophageal junction, or the cardiac at the lesser stomach. Whereas this one is in the posterior 1/3 of the lower esophagus.
Okay.
And here, no, the patient will present as chest pain because here, no, there is complete tear of the esophagus.
Okay.
So what? So what will happen? Once the tear has happened, the gastric content or the esophageal content will enter the what is present next to the esophagus is the mediastinum.
Yes.
So what? You will have chemical mediastinitis. What I told you, itis means inflammation.
Yes.
So why it is called chemical? Because all the contents of the stomach and the chemicals enters into the mediastinum and will cause medical mediastinitis. And because of mediastinitis, there will be crashing of the BP and the patient will go to shock.
Okay.
Okay. So what is the investigation we have to do? Since there's a bone there, you can't do endoscopy. And if you do endoscopy, also, what will happen? The endoscopic tube will go into the tear and cause more tear also. Only. So we can't do endoscopy. So what is the next option to see? It is CCT chest.
Okay.
That is contrast enhanced CT scan.
Okay.
Okay. And the contrast used is gastrographin.
Okay.
Yeah, remember that. They might ask you in Viva, what is the contrast most commonly used in contrast enhanced CT? Is mostly gastrographin.
Okay.
Yeah. And the treatment is what do you give? NG suction. That is a nasogastric tube. Have you seen a nasogastric tube?
Yes, sir. Yes.
Yeah, that one with that you use the suction. Then see, I told you inflammation. So what will cause inflammation and cause infection also. So what you have to give? Antibiotics. And it's a tear. So what you have to do? You have to do surgical repair of the tear.
Okay.
So now you understood Voorhees syndrome. Voorhees is actually complete tear of the esophagus, whereas Mallory West is only the submucosal tear.
Okay.
Mallory West, where it is found? It is found in cardia and the lower esophageal sphincter.
Yes.
In lower esophageal gastroesophageal junction. No, sorry, not lower esophageal sphincter. Gastroesophageal junction.
Yes.
It is found. So whereas what in Voorhees syndrome, where it is found? It is found in the lower 1/3 of the esophagus and it's mainly in the posterior surface.
Okay.
Remember that anterior surface it can't tear.
Okay.
Because there is a bone support. So what will happen? Posterior surface will tear.
Okay.
Remember that. In Voorhees syndrome.
Okay, sir.
And Voorhees syndrome is complete tear.
Okay.
Never forget this. They might ask you for 3 marks also. Classify between Mallory West and Voorhees syndrome. Well, a lot of people will always get confused.
Okay.
So it's a pakka question they'll ask you.
Okay, sir.
Next is Delphi's lesion. What is Delphi's lesion? It's a single large tortuous arteriole in the submucosa. That is, arteriole is dilated and it's like a varicose. Have you seen a varicose vein?
Yes, sir.
Yeah. Same way, this arteriole is dilated in the submucosal region of the esophagus. And it is do not undergo normal. There is no branches for this arteriole. Its caliber. Caliber means its width or diameter is about 1 to 5 mm.
Okay, sir.
And its lesion, since it's a dilated, it'll when food passes through it, it will cause a rupture of this arteriole. The lesion bleeds into the GI tract through a minute defect in the mucosa. Because when the food passes through it, there will be a small injury to the arteriole and it will cause bleeding into the GI tract. Due to the and it may be due to since there is protrusion of the arteriole causing the injury. Okay. You understood what is Delphi's lesion? It is a tortuous arteriole. Remember, it's varicose arteriole type because arterioles varicose is actually veins. So I'm just comparing it with a vein. But remember, it is a arteriole.
Yes, sir.
Now I told you causes of upper GI bleeding. Now you understood the causes and your etiology you understood. Now how will you and the symptoms also you understood. So now how will you manage an upper treatment of upper GI bleeding? First hour when the upper GI bleeding, mostly when it comes, when the patient comes to a casualty, always, always when you study, remember a case in front of you. Now the patient is come to casualty, and always the casualty cases, GI bleeding cases, will come in always shock. Shock means
Okay.
he needs airway, breathing, and circulatory support.
Okay, sir.
Okay. So now what we have to do the airway breathing, you have what's I told, and next is resuscitation. That is the circulation.
Okay.
Resuscitation, what do you do? We give IV fluids. IV fluids, crystalloids are given to raise the BP.
Okay,
Then
sir.
blood transfusion, bleeding. Bleeding means he will go into, he needs a lot of blood. So we have to
Okay.
give blood transfusion if the patient has active bleeding. And oxygen, as what airway. Oxygen if
Yes.
patient is in shock. Then
Okay.
next, once you have stabilized the patient, next you have to investigate. We have to find out where the bleeding spot is,
Okay, sir.
and we have to treat the bleeding spot. That is, we have to do endoscopy. Except Borhe syndrome, we have other all malarious tear also. Other malarious tear also we do endoscopy. Except Borhe syndrome, other all we do endoscopy.
Okay.
In Borhe syndrome, it is complete mucosal tear and it causes biomedical mediastinitis. That's why we do CECT. Is the investigation of choice.
Okay, sir.
So endoscopy is done after adequate resuscitation. Stoppage of bleeding spots either by thermal or mechanical modalities such as heater probe. That is, thermal means we coagulate,
Okay, sir.
and it's used by, we do it by heater probe or by endoscopic clipping. That's the banding technique or the clipping technique.
Okay, sir.
In surgery, you have read about what esophageal varices, upper GI bleeding, how we do banding.
Okay.
You can find out in that.
Okay,
Then
sir.
if this doesn't work, along with these, sometimes some gastroenterologists or surgeons, they give endoscopic injection of epinephrine for a temporary control of the bleeding because it causes vasoconstriction.
Yes, sir.
So it will control the bleeding. And
Yes,
next
sir.
is surgery. When the endoscopic hemostasis fails, surgery is done for the patient.
Okay, sir.
Now we'll come to, until now I told about upper GI bleeding. Now we'll come to lower GI bleeding. Lower
Okay.
GI bleeding is caused by the hemorrhage from the colon, or
Okay.
it might be due to anal canal bleeding or small bowel bleeding. Small bowel from the jejunum and the ileum. So
Okay.
it's useful. What is the use of this? It's useful to distinguish between patient with profuse, that's the acute bleeding. So this lower GI bleeding, it might be acute. Goes with
Okay.
chronic or subacute bleeding of lesser severity. So acute bleeding will be like if you have hemorrhoid, today you
Okay.
start bleeding suddenly, or
Okay.
sometimes some small hemorrhoids, big hemorrhoid. Whereas small hemorrhoids, he will be bleeding daily.
Okay. Okay. Okay,
So
sir.
acute bleeding, he might not, he might have present symptoms only. There might be not so much hemoglobin, it might be not be losing. But when there is subacute bleeding, when he's bleeding every day, small, he
Mm.
might not know his blood loss, how much he has lost.
Okay.
So he
Okay.
might have very deficient hemoglobin and he might be needed blood transfusion. Like, so one example I'm telling. So
Okay, sir.
lower GI bleeding, we need to distinguish between acute bleeding and the subacute bleeding.
Okay, sir.
Okay. And next is, what are the causes of lower GI bleeding? Severe acute causes are diverticular disease, there's a diverticulosis, then angiodysplasia, then ischemia, then Meckel's diverticulum. Meckel's diverticulum is second most common cause of bleeding in children. And
Okay.
inflammatory bowel disease also leads to lower gastrointestinal bleeding. Then
Okay.
next is moderate or chronic subacute bleeding is seen in fissures, anal fissures, then hemorrhoids. I told you, right? Hemorrhoids. Then inflammatory bowel disease also moderate or chronic subacute bleeding can be seen. Large polyps, there will be, and carcinoma also is seen. Radiation enteritis and solitary rectal ulcer.
Okay.
Just you need to know if you are like examples like fissures, hemorrhoids, inflammatory bowel disease, carcinoma, large polyps. Just to keep in mind.
Okay, sir.
Yeah. The next is like now I tell the classification of lower GI bleeding. It is severe acute lower GI bleeding. Is seen
Okay.
in, is present with patient presence with profuse red or maroon diarrhea, and at times with the patient, since it is severe acute lower GI bleeding. So the patient has present bleeding. So since it will be heavy loss, the patient might present with shock. Same like upper GI bleeding.
Okay, sir.
Most common cause of severe acute lower GI bleeding is diverticular disease. There's a
Okay.
diverticulosis. You know what is diverticulosis, right? On
Yes, sir.
the GI tract, there will be small pockets of extension,
Oh,
diverticuli.
yes,
That
sir.
is called divert. And these in this how there will be bleeding in diverticular is due to erosion of an artery within the mouth of the diverticulum, causes the bleeding, and bleeding can be either acute and profuse, and
Okay.
usually stops. It might actually stop spontaneously, but it can also recur again and again. So
Okay.
that will cause again more and more bleeding. What is the
Okay.
investigation to be done in severe acute lower GI bleeding is colonoscopy. Remember, it is in the rectum and lower in a large intestine, and in the second like jejunum and ileum. What type of investigation is? You can't do endoscopy. We'll do colonoscopy.
Okay.
So
Okay.
characteristic vascular spots are seen, and if you find very large bleeding blood vessels, you do what? Visceral angiography is done. Bleeding into the intestinal lumen and large abdominal veins are seen in visceral angiography.
Okay.
Okay. So visceral angio, see, angio means vessel, graphy means find study of the vessel. That's
Okay.
visceral angiography.
Okay, sir.
Next is treatment. What's the treatment to be done? So you do treatment same like upper endoscopy only. We do endoscopic thermal ablation. It is the treatment of choice. Then if that doesn't work, what you do is resection of the bowel if the bleeding continues. That's the inflammatory bowel disease. And if there is divertic or heavy bleeding, you have to save the patient. So we have to dissect the bowel and throw it off. And we will the stomies.
Okay.
Yeah. Then what are the complications due to this acute bleeding? There will be what causes the resection of bowel? That's the main thing. Complications like bowel ischemia, when there is decrease, when the blood is lost and there is no this bleeding of the blood vessel, the region above it or the region below it, sorry, not above it, below the bleeding spot will start not getting decreased blood vessels. So that
Okay.
area will start getting deoxygenated and it will cause ischemia. So bowel ischemia, if occlusion of the inferior mesenteric artery is seen, is present with abdominal. So patient might present with when there is bowel ischemia, the patient might present with abdominal colic. Abdominal colic means abdominal pain, and there might be rectal bleeding also.
Okay.
Got it till now?
Yes. Yes, sir.
Okay. So now we'll come to subacute or chronic GI bleeding. So that was acute bleeding. Now it is chronic. So what did I tell about chronic? There will be small bleeding every day. So most common due to hemorrhoids or anal fissure. You know what's hemorrhoids? Small hemorrhoids to start. They'll become slowly, it becomes dilated and off the veins become big. So once this small hemorrhoids, when the stool passes, there might be small bleeding spot, but it won't be as much as before. When it becomes big, it starts getting worse and the patient finds difficult. Up to then, there will be subacute bleeding. So the
Okay.
person will have small bleeding spots, and in anal fissure also the same thing. Hemorrhoidal bleeding is bright red because it's fresh bleeding is bright red in color, and it occurs most common during or after defecation. Defecation means passing of stool.
Yes.
What do you do for investigation? Since it is present in the rectum, we use proctoscope. Have you seen a proctoscope?
No, sir.
Have you seen a proctoscope?
No, 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 sir.
No. Okay, fine. When you next time you go to surgery,
Yes,
it is
sir.
it's the most common instrument used in surgery, especially
Okay.
to see the rectum. It's a
Okay.
triangular shaped instrument,
Okay.
steel material. So
Okay.
it is actually used in surgery. So when
Okay.
next time, like we will go to in instruments you see, right? That time
Yes.
we just try finding a proctoscope.
Yes, sir.
And if next time, no, when I like show you the slides, right? Next class, I will show you
Yes.
a proctoscope. So I
Okay, sir.
want you to know that because it's commonly used.
Yes, sir.
Yeah. Then once if you don't find in proctoscope, that time we do a colonoscopy to rule out rectal CA.
Okay.
The anal fissure is suspected when rectal bleeding and anal pain occurs during. So if the patient has only rectal bleeding, it is hemorrhoid. But if the patient has rectal bleeding and anal pain during defecation, then it is you suspect an anal fissure.
Okay.
Got it. Oh.
Okay.
So next is what is hematochezia. Hematochezia is passage of fresh blood per anus with or in stool within the stool. So it's a passage of fresh blood per anus in the stool because hemato means it is fresh blood. That is chezia.
Okay.
Next stool. So what are the causes? It is most common seen in diverticulitis, that is inflammation of the diverticuli. That is the diverticulum which I told you before, or
Yes.
it is mostly seen in hemorrhoids. That is fresh bleeding in stool is seen in
Yes.
hemorrhoid.
Yes.
But in pediatrics, most common cause of hematochezia is rectal polyp. More than I told you, Meckel's diverticulum. So if there is a rectal polyp, more common cause of hematochezia in pediatrics. But if there is a diverticulitis, if they don't mention, they don't mention question what's the most common cause of hematochezia, adult or pediatric is not mentioned, then it is always diverticulitis followed by hemorrhoids.
Okay.
Next, this is also seen in inflammatory bowel disease. There are two types of inflammatory bowel disease, that's ulcerative colitis and Crohn's disease. In ulcerative colitis, most commonly it is present with bloody diarrhea, whereas in Crohn's disease, most commonly patient present with colicky pain, and there will be stricture formation. You know what a stricture is? The between the two walls of the GI tract will be stick together, and they'll form a obstruction.
Yes.
And it's most commonly seen in Crohn's disease there,
Yes.
more than bleeding. Whereas bleeding hematochezia is also saying cancer colon. Whereas remember that most commonly the bleeding is seen in cancer colon of the right side than the left colon.
Okay, sir.
Yeah. Then it's also seen acute mesenteric insufficiency because due to embolism of the mural thrombus to superior mesenteric artery or the inferior mesenteric artery. So once there is a thrombus within the blood vessel, that is the superior mesenteric artery and inferior mesenteric artery, there will be blockage of the blood supply. What does it cause? It causes decreased blood supply to the mesentery and it will cause mesenteric insufficiency or ischemia.
Okay, sir.
And it occurs 2 to 3 days of following mesenteric ischemia. Following MI, not MI, mesenteric following MI. That's a cardiac event. You can see 2 to 3 days following a cardiac event. And when there is a MI, how is MI caused? Decreased blood supply to the heart muscle.
Yes.
Why decreased blood supply? Because due to thrombus.
Yes.
And this thrombus might dislodge and enter into the superior mesenteric artery or inferior mesenteric artery, causing decreased blood supply to the mesentery.
Yes, sir.
So for this mesenteric insufficiency, what is the investigation of choice is angiography, and treatment is same like heart MI. The treatment is thrombolysis.
Okay, sir.
Next is angiodysplasia of colon. Abnormal presence of angiodysplasia means there are small bleeding spots in the mucosal structure of colon. So it's abnormal presence of submucosal bleeding within the colon. It's called hematochezia.
Okay.
Okay. So now you understood the cause of hematochezia.
Yes, sir.